Hi, this is Brian Kim. I'm going to share with you case number 126 in the best way to do cataract surgery series. This patient has a really giant pupil, and so you'll be able to see the lens disassembly doing double chop and cross chop very easily. The anatomy is really nice. This is also a soft lens, and you're going to see very efficient and easy lens disassembly using the same techniques. Now, with other techniques, especially with like vertical chop, you can't vertical chop the soft lens. It's really not the right technique. You try to lollipop it and do that sharp tip kind of scissoring vertical movement, and it's just not going to fracture. It's just not designed for that technique. You can try to do divide and conquer, but then divide and conquer, as you're doing the trough, the lens is just kind of falling apart. So instead of having a cross-shaped trough, you just have bowled out the lens, and then now you're going to try to grab it with vacuum, and it's just close to the posterior capsule. It's just not really safe to do it that way. Some people will just prolapse the lens up, this flip and into the anterior chamber technique, which is fine, I guess, if the chamber is really deep. But what if the chamber is not, and you're going to potentially bring this giant lens up into the anterior chamber and scraping the corneal endothelium and causing significant trauma. And so this technique is just so easy, double chop, cross chop, so versatile with every single situation. And so you're going to see how I'm able to achieve that with this case. So I use a corneal marker, which will help me to center and size the rhexis. And then I make my incisions first on the right side and then the left side. Make sure I'm flat to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I inject some intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the cornea and flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. And this is the Haldi-Perkar cross-section forceps. I'm able to puncture centrally with this forceps. And you can see the teeth open so nicely. And because it's low profile, you see that it's not really causing much corneal stria, even though I'm using this technique in the subincisional area. Oftentimes, when it's a non-cross-action forceps, when you're trying to pinch the rhexis in the subincisional area, it causes so much corneal stria and distortion. And so I've learned with these cross-action forceps, you have much less subincisional corneal stria and distortion with these types of forceps compared to the Utrata style forceps. So I'm using the corneal marker as a guide as I make my rhexis, which helps with the size and centration. Finish off the rhexis. This is the Capsulorhexis hydrodissection technique. Place a cannula out on the rhexis edge contra-incisionally. Get a beautiful wave, decompress on the left side, and then spin the lens on the right. You can see how big this pupil is, and really when I place the chopper out, I'm not going to the capsule. So I'm not going to get the chopper near the capsule. You don't have to worry about the posterior capsule being ruptured. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I'm going to just place the chopper between the epinucleus and endonucleus right there, pointing the phaco tip vertically subincisionally, and it fractures the lens. Placing the chopper on the right heminucleus, pulling it centrally, fractures the lens. It's such an easy and efficient technique. You're able to use some vacuum to grab that first quadrant up, and it's so soft, it just kind of falls apart. No ultrasonic energy here. Placing the chopper under the rhexis edge here, under the second quadrant, lifting it up. You can see there's a split between the epi and endonuclear interface. So again, the chopper only goes out to the epi and endonuclear interface. Now, even if I go further out, it doesn't matter, because what I'm really cutting is that. That's what I'm actually fracturing. If I place the chopper a little bit further out, it's not going to do anything. It's not going to harm anything. But what's being fractured is the endonucleus. Even if I cut through the epinucleus a little bit, it's really a non-issue. But as long as I can get the chopper around the epi-endonuclear interface, I'm able to fracture the endonucleus quite effectively. So again, this is a very safe way of disassembling the lens with the double chop and cross chop technique. Very efficient, very easy. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece, starting sub-incisionally, removing the cortical material. Because of the machine is so efficient, I'm able to just peel it off with the vacuum. Go ahead and switch to polish mode, polishing under the rhexis edge. You can again see the anatomy so nicely and clearly due to this giant pupil. Polishing the posterior capsule as well. Pulse some BSS into the subincisional capsulorhexis. It was nice and clean. Injecting some cohesive viscoelastic to fill the bag. Go ahead and sweep the capsule with the shepherd polisher, starting subincisionally. And the sweeping motion is kind of rotating the instrument upward, rolling the instrument between your fingers. You can see the lens epithelial cells coming off. First on the left side and then now on the right side. Again, using that instrument's a little bit cumbersome, but it does a really beautiful job in cleaning off the lens epithelial cells. Go ahead and switch to the Singer sweep side and polishing under the subincisional capsule as well as the right side. So this is the single piece acrylic lens that's going into the capsular bag. Go in with irrigation off, activate irrigation, making sure both haptics go within the bag. Make sure the haptics are off the optic. Tilting the lens and rotating it 90 degrees, removing all the viscoelastic from within the bag, putting the optic back in, polishing under the rhexis edge a little bit more. Getting under the lens and removing some more fine lens material. Removing the viscoelastic from the anterior chamber, and then I'll hydroband incision. So again, with other techniques, you have to kind of switch. Well, if it's too soft, I can't do vertical chop, so I'll have to do a flip technique because vertical chop's really not very efficient with soft lenses. You'll end up stabbing it and it won't really cut. I'm going to try to, divide and conquer it, but then when you do that, the lens just kind of falls apart. You can't really crack it because it just cheese wires. So, flipping it and doing these other techniques, I just feel like that's really not a good technique. If you have to switch techniques based upon the clinical scenario, whether it's a soft or a dense lens or a small pupil, big pupil, that means your technique is limited. And so I've kind of developed this technique because it is really very versatile. I can do it in any situation. I can keep the lens pieces away from the cornea. All the lens manipulation is within the capsular bag, and at the iris plane, I'm able to use mechanical forces to basically cut the lens pieces. This concept of mechanical fracturing has become more popular with the advent of pre-choppers, as well as now the MyLoop that's come out. And so the concept of using mechanical forces to amputate pieces so you can disassemble the lens piece has been around for some time, but why use a different instrument when you can use the same instruments you've been doing and using with the regular cataract surgery? And that's kind of why I like this technique. If you buy a pre-chopper, you have to use a pre-chopper to disassemble the lens, and then you take it out, and then you have to go back to your regular instruments. If you want to use the MyLoop, you have to invest in a new instrument. You learn how to use that. But if you can master with just your regular phaco tip and second instrument how to fracture the lens into smaller pieces, whether it's a soft lens, a semi-soft lens, a dense lens, a hard lens, and very efficiently and systematically crush the lens and bisect them into smaller and smaller pieces, you get less ultrasonic energy use, less chance for complication, clearer corneas postoperatively. I just feel like this is a no-brainer. And if you don't try this technique, you're really shortchanging yourself and you're really shortchanging your patients. And so again, all it takes is some manual dexterity, some care and attention to detail, and just a commitment to get better as a surgeon. And that's what I've done. And I feel like now that I've gotten to this stage, of course, I'm always open-minded to other things that can be better than what I'm doing. And I think that's the sign of a great surgeon, is that you're not going to settle to a technique that you've always done just because you're afraid of trying something new. The patients deserve better than that. Patients want the best. They don't want, oh, I've done it this way for 20 years and there's nothing wrong with that. That's what the extra cap surgeons said when they were looking at the phacosurgeons. So we really have to think forward. We want to think innovative. You want to think efficient. You don't have to buy other instruments. You don't have to add and use other instruments unnecessarily, going in and out of the eye. Using less instruments is more efficient, more flow, and overall better for the patient, safe for the patient, clearer corneas, like I said, less manipulation. And again, this is why I fervently believe this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.